Good afternoon, everyone. Welcome to the webinar Powering Healthcare Sustainable Energy for Humanitarian Health Response. My name is Ranisha Basmith, and today I'll be moderating this webinar along with my colleague Lisa Fellman from Energypedia. As you all know, this webinar is a joint collaboration between Energypedia, UNITA, and ICRC, and is part of an ongoing webinar series. So I do invite you to check out our past webinars where we have touched upon different issues within the humanitarian energy nexus. You can find a link as well as the video from past webinar on the webinar documentation page. And we will also share the presentation and video from today so that you can have a look at them. And since it's part of an ongoing webinar series, we will also come up with new webinars. So please give us your feedback on what topics would you like us to address, and we will try to design webinars accordingly. So before we kickstart with the webinar, a small tip. On the right side of your screen, you have a control panel. There you have an option called as questions. When you click on that, a box will appear where you can type in your questions. So please use this option to send us your questions during the webinar. So what we will do is we'll collect all the questions that come in and then address to the respective speaker towards the Q&A session. Therefore, please do tell us to whom the question is addressed to, for example, speaker 1, speaker 2, or from a particular organization, so that we can address them to the respective speaker. So let's kickstart the webinar by knowing a little bit about you, the audience. So a poll question should now pop up on your screen. Sorry, it's taking a bit of time to launch the poll. So now you should have a poll question on your screen, and do tell us where you are tuning in today from, whether it's Asia, Africa, Europe, Latin America, or any other places. So I see the answers are coming in, so I will leave it for a few more seconds. Maybe we leave it another few seconds as people, I can see our audience are typing in their responses. And now I will close the poll and display the result. So we have a lot of people today tuning in from Europe, followed by Africa, Asia. So welcome to you, all of you, one more time. And now we have a second poll question popping up on your screen. So please tell us, in which sector do you work? Do you work in the energy sector, humanitarian sector, or the healthcare sector? This is to understand you, the audience, better, so that we can design webinars that are more useful to you and just to understand you better. So I see the answers are coming in, so let's leave that for a few more seconds. And now I will close the poll and display the results. So we have a lot of people who are working in the energy-related organizations, followed by humanitarian and research institute. I hope this webinar will be useful to all of you. Now, coming back to the webinar, I want to briefly run through the agenda for today. Today, we have 3 presentations. We will start with the presentation from Sustainable Energy for All, followed by a case study from MSF Spain. And then we have an independent energy consultant presentation from an independent energy consultant, specialist, sorry. So I want to kickstart this webinar by introducing Nan Buzard from International Committee of the Red Cross. Nan is the head of innovation at ICRC, and today she's going to briefly talk about why this uncertain times like COVID also present an opportunity for renewables to grow. Nan, the floor is yours. So if you could quickly unmute yourself, you could proceed with your talk.
Thanks, Ranisha, and hello, everybody, all 200 plus of you. After 2 months, it's really great to resume this Sustainable Energy webinar series. ICRC, with its partners UNITAR and Energypedia, have been working together and we love this outreach and this partnership. We wanted to take a moment today to recognize the links and the implications between all our efforts towards sustainable energy and this current COVID crisis. I bet there's not one of you who has not been impacted, and probably many of you quite intensely. This situation is and will have prolonged effects with many unknowns and many uncertainties. However, unfortunately, we are certain that the effects of conflict and violence in many humanitarian settings will not decrease. However, I just want to point out that while it's a time of crisis, it's also going to be a time of profound transformations. We don't know what those transformations are and which ones will emerge. But as someone who's been in disaster and emergency response for a long time, I do know that crises require adaptation, and they can often open the way for good and important ideas to accelerate. Ideas whose time has come. So just take a moment to consider this. Over 60 years ago, the 1953 global polio outbreak led to a physician innovating with a ventilator that saved lives, and more than 60 years later, medical practice still builds on that moment. Consider the terrible morbidity in refugee camps in the DRC following the 1994 Rwanda genocide. It was the catalyst for many things, but also the development of the Sphere disaster response standards. The 2006 tsunami led to breakthroughs in the use of mobile cash. The 2010 Haiti earthquake accelerated mobile communication and crowdsourced geo-mapping. The list goes on. This pandemic requires states, local communities, and the international community to scale up support where there are weakened health systems and limited capacity to respond. Now, promoting renewables, increasing investments, fast-tracking research, all these can increase system resilience at a time when power supply for health facilities must be guaranteed. There is a strong link between renewables and this moment in time. At the ICRC, our actions continue, as well as our commitment to sustainable power supply for health facilities. We will adapt our response and continue to provide lifelines to those in need due to armed conflict and violence. All of us must find our ways to accelerate our work, to share our learnings and knowledge, as this webinar is doing, and use our collective willpower and our collective intelligence to inspire acceleration and advance our energy transformation. Some of you might have seen that we just there was just a new report out from the WEF that is showing progress in clean energy, but also the unprecedented disruptions from COVID-19 that will threaten transitions. I just want to say to all of you that we need to stay connected, we need to collaborate, and we need to move forward and try to make silver linings out of this very, very difficult time. I hope all of you stay safe, and I want to thank the presenters for today's webinars for the work that they've done and that they will be sharing with you today. Thank you and take care.
Thank you, Nan, for your kind words, and are definitely also shedding the light that this uncertain time can also be a time to grow and expand. And now moving forward, I want to start the webinar with the first presenter for today. His name is Luke Savary. Luke is a senior energy access specialist at Sustainable Energy for All. And today he's going to set the scene on why access to energy is important for powering health facilities. Luke, the floor is yours, so please unmute yourself and start with the presentation.
Thanks so much, Renisha, and thank you to your colleagues at Energypedia and our friends at Untitled and ICRC for this webinar series, and thank you for inviting us to do a bit of a scene-setting presentation around powering healthcare, which is a topic that me and my colleagues have been working on for the for the better part of the last half decade, previously under the UN Foundation, and since last year under the umbrella of sustainable energy for all. So in the next 10 minutes or so, I want to provide a very briefly just a recap of what is SDG 7 and where are we. So what progress have we made, or what progress do we still have to make in the next 10 years? I'll quickly move on to why powering healthcare. So what is the importance of energy, of reliable energy and electricity for improved health outcomes? I'll then talk briefly about the scale of the problem. So once I've convinced you that it is a problem, I'll tell you how big it is. We'll, of course, stop talking about problems and quickly dive into solutions, especially on the energy side. So both on the energy supply side with the technologies and on the energy demand side with appliances. And then I'll try to spend the bulk of the remaining time around some COVID-specific barriers that we know exist today that are impeding a rapid deployment of solutions in spite of an increased engagement by civil society, private sector, the donor community, and the public sector. Next slide, please. So first, SDG 7, hopefully well known to all of you, but just as a very quick recap, it has 3 targets, one on energy access, under which we count electrification and clean cooking, one on renewable energy as part of the global energy mix, and the third one around energy efficiency. Next slide, please. So where are we today? Just to note that these numbers come primarily from the Tracking SDG 7 report, which is launched every May, so the month of May of every year. So at the end, and I think in a week or two, we will have updated figures here. But in terms of order of magnitude, this is a good starting point. And I'd encourage you to focus on column 1 first, where we clearly see that we still have we have less than 1 billion people that are completely unelectrified today, but it's still, the number is still quite high. And what is not captured in this graph is that on business as usual, so not even taking into account the current COVID crisis and the impact it has on the energy and the energy access sector, we still would have more than 600 million people by the end of 2030, so by the end of the SDGs. The numbers are maybe even more stark in the middle column around clean cooking, access to clean cooking technologies, where we are just below 3 billion people on this earth. And then the third column is something that we often neglect to talk about, which is access to cooling, which is something that impacts not only the developing world, but also the more developed the developed world in terms of access to cooling in a world with rising temperatures. Next slide, please. So on to the focus to powering healthcare. So on the top part, we see the targets again reiterated, but we know that powering healthcare it's a nexus issue, and that's why it is both so important but equally so complicated, because it's not as simple as just focusing on one particular sector. We need to bring together the power side with the healthcare side, so the energy community with the health community, and because it's a nexus issue, it needs a joint approach, a consolidated approach between these sectors. And even though we tend to focus on SDG 3 and SDG 7 when we talk about powering healthcare, I've listed out several other SDGs that we should not neglect either, or that are equally impacted when we focus on powering healthcare, when we focus on ensuring that every health facility has access to reliable power and to sufficient power. I'm just going to highlight 2, namely SDG 5 on gender equality. We know that it's when we look at primary healthcare facilities, the impact is primarily on maternal child health. When we talk about where does energy come into play. Also want to highlight briefly SDG 13 on climate action and indicating that health facilities can be an active participant, can be an active contributor to climate to the fight against climate change and to building both climate resilient health sectors. Next slide, please. So this is just a brief summary of all the different areas that electricity plays a role in health service delivery. I think we all know, we can always come up with a few examples. For example, of course, electricity can power life-saving appliances. It can keep the vaccine refrigerator running to keep the vaccines at the required temperature. It's needed also for non-medical appliances, for example, sterilizing equipment, pumping water, having security lights, but it also allows for a quality of life for the health facility staff that live on site and allows them to do the job that they were hired to do. Next slide, please. Unfortunately, this is what it all too often still looks like. Next slide, please. All these percentages just tell you how stark the problem is. It tells you the scale of the problem. It tells you how many facilities are still affected. And because of that, how many people are still affected by energy poverty in their health-seeking behavior. I'll skip over this quickly so you can move to the next slide, but I wanted to put these out there in case we wanted to refer back to them after this webinar. I added this slide as well, which is more of a quality of power slide, where it's not a binary indicator. We shouldn't look at powering healthcare as a binary indicator in terms of is there power, yes or no, because then we often neglect the granularity of this problem. If we look, for example, on the top part, on the darker blue part, which is how many facilities are connected to the national grid, and we compare that to the second part of the slide, being connected to the national grid clearly doesn't mean that we're in tier 5. It doesn't mean that we have reliable power 24 hours in a day. Equally, having some kind of solar PV generation, again, it doesn't mean that is necessarily sufficient. So we want to make sure that solutions that are provided, that they're appropriate, that they're reliable. Next slide, please. So luckily, we have seen a massive suite of innovations on the energy side, both here on this slide on energy technologies, where there are a range of solutions that address different parts of healthcare and different parts of the problem, from very easily deployable, smaller portable solutions all the way up to community-wide mini grids that provide basically a utility-style power. Next slide. But also on the energy efficient medical equipment side, are we seeing a lot of innovation to make medical equipment more appropriate for resource constrained settings, but also to make sure that they are actually able to be powered by the limited power that tends to be available, if power is available at all. And energy efficiency is not purely a power consideration, it is also an economic consideration in terms of how much can be saved when you replace the existing appliances with more energy efficient appliances. So it's not only about developing energy efficient appliances, it's also about making sure that they're available where they're most needed. Next slide, please. Good, so I only have 2 slides left, so I don't need to rush through this one. And I hope that this can be a bit of a framing for the remainder of the webinar. But we've been receiving literally thousands of questions from civil society, from public sector, from private sector, from the donor community in terms of how can we help, what can we do, how many facilities are we talking about, what do they need, et cetera, et cetera. And while there is a lot more willingness to engage in this topic, we see that we've tried to categorize them into these 6 different barriers that still exist. So I'm just going to briefly run through them all. So the first one is about data. In a very simple way, we need to know where are the health facilities, which ones are COVID-19 specific health facilities, which ones will be treatment units, where will there be testing, et cetera, because that links to the next barrier on knowing which electricity-dependent medical appliances should be in use, should be deployed, potentially are already at these health facilities, but more often than not will not be. But equally, which appliances are actually needed when we talk about a COVID-19 specific response? That leads to the third bucket on system design. So we want to make sure that we supply sufficient power, that we supply reliable power, especially when we think of the need for ventilators or for a continuous oxygen supply at the treatment level, at the ICU level, so primarily with district and regional hospitals. There needs to be continuous power, because any kind of power interruption can lead to the loss of a life. So we want to make sure that the systems are appropriately designed, both for the short term as well as for the long term. And that's where trying to find the right energy technologies between, as we know, especially in the humanitarian sector, how quickly diesel gensets can be deployed versus how unreliable they actually are. So it's about finding that right balance between short term and long term, and between technologies that may be easily deployable versus those that are much more sustainable, both financially as well as environmentally in the medium and longer term. The fourth barrier is about financing. So we do see that there may be more financing available, more funding and financing available for powering healthcare in this COVID-19 world. However, how quickly can funds be dispersed? How will funds be divided between CapEx versus OpEx? And for those of you who are not familiar with those terms, with CapEx we mean the capital that is needed up front as part of the actual installation, the procurement of the goods. The OpEx is the operational part, because there is no such thing as zero maintenance. Even with solar PV, it is limited maintenance, but there is still maintenance that is needed to ensure that systems continue to perform and deliver the required energy service that they were procured to do so, because otherwise systems can fail literally within 1 or 2 years, rather than the lifespan of the separate components. The fifth one is a very important one in COVID-19, which is, what is the capacity of the sector today? And by that I primarily mean the energy access sector, to be able to respond. So even if we know on the first barrier, we know which facilities we're talking about, we know which appliances they need, we know how much power they need and what the system design will look like, and we've got some financing unlocked from a donor or an investor, there remains a big question today in terms of what is the capacity of solution providers in terms of all the supply chains that are interrupted. What are the current inventory levels? Is the country on lockdown? And as such, it is very hard to send people out to health facilities to carry out this type of work. How do we unlock that barrier? So it's an important one, and maybe the most COVID-19 specific one. And then the last one that brings all of it together is sustainability, because we do know that there is a tendency to act in an urgent way, to rapidly deploy solutions, but that doesn't mean that we should neglect the longer term sustainability, because we do have an opportunity here to address this problem once and for all, and to really garner this momentum that COVID-19 has unfortunately, but has provided us with, and make sure that we find the appropriate business models, the appropriate deliverable models, to make sure that the energy solutions that are deployed today and tomorrow, that they continue to deliver, also in a post-COVID-19 world, and that they contribute to a resilient health sector, not today, but also tomorrow, 5 years, 10 years from now, 15 years from now. Next slide. So this is my last slide, just as a recap, both looking in terms of the barriers that exist, but especially in terms of what SE4All is currently involved in, so that you know as well, like, how you can rely on us with your questions or with your solutions. So firstly, as has always been the case, we are doing a lot of sector-wide coordination. We are bringing together the energy and the health community, as we have been in the last couple of years. because we see the importance of approaching this not exclusively from one single sector, but in an intersectoral way. So that includes mapping current resources, assessing the capacity of energy access developers, highlighting these barriers, doing the high-level advocacy that is also needed between, especially at the higher level, at the global level, between the likes of WHO, UNDP, the key energy donors, et cetera, et cetera. We're also doing a lot of work on the data side, trying to map out what are the ongoing interventions, which ones are planned, how can we match this big supply that we are seeing that's being created with an equally big demand where the two don't necessarily overlap with each other. So how can we map those two out together? We're also developing a lot of guidance documents, a lot of tools and resources from both ourselves and our partners. So on the far right of the slide is just a screenshot of our COVID-19 response page on the SE4All website, where we've already collected more than, I don't know, I think we came up to about 16 technical resources already. Funding opportunities are being advertised there as well as just a general in the news section, so we can all stay up to date in terms of what is happening, who is doing what. If I want to engage in this particular country, who would be good actors to involve in? But as in the past, just to reiterate, that Powering Healthcare does want to remain that central hub, that first port of call for powering healthcare, to make sure that we tackle this problem in a joint way, in a joint approach, because with this increased attention, of course, comes a risk of duplication, but there is also a tremendous opportunity for synergies and for really addressing this in the most sustainable way. Last slide, please. Which is just the final title slide and my contact details. This is where I close, and I give the stage back to you, Renisha.
Thank you, Luke. Thank you for such a nice overview. And like you mentioned, powering health is a nexus issue, and it also requires collaboration between the energy practitioners, the health practitioners, and also thank you for shedding light on special COVID-19 activities. I think that will be useful to a lot of our audience. Now, moving forward, I would like to welcome my second presenter for today. His name is Inaki Goikola. Sorry for the mispronunciation. Inaki is an electrical engineer working with MSF Spain, and he has many years of experience in the humanitarian world. Today, he's going to share his experience from the Democratic Republic of Congo. So Inaki, the floor is yours. Please unmute yourself and begin with the presentation.
Thanks, Renisha. I would like to thank Energypedia and Unitar for organizing this webinar, which I think is a wonderful opportunity to talk about these important issues. So, as you said, I will present this case study about these photovoltaic systems that we installed in the towns of Kusisa and Kibulube, both in the South Kivu province in DRC. Okay, next slide, please. We will cover a brief introduction of what we did, the design of the system, its implementation, the operation and maintenance, what were the costs, and the impact of these two solar systems at humanitarian level. Next, please. So, as I said, these are two solar systems that were installed in these two villages called Kusisa and Kibulube, both in the South Kivu province. Both are very, very remote areas, okay, in the middle of the jungle. So the access is quite difficult. Just for to give you an idea, most of we were traveling by helicopter or by motorbike, which took 2 days from the province capital, and to send materials by truck, it took around 1 week, between 5 and 10 days, depending on the season. Okay, in both places there are 80-bed hospitals which act as the medical reference center for all the region. Okay, and MSF is supporting and was supporting at the time of the installation both facilities. In both facilities, MSF already had diesel generators running in place. Okay, and just to give you a broad idea, they were consuming between 20 and 30 liters of diesel each generator each day. Okay, this was clearly unsustainable. One, due to the high cost of delivering the diesel to these places. Our calculations were that it cost around between $5 and $7 per liter. Okay, due to the remoteness, and also for the logistics or something that diesel to those places, because we could only send it with motorbikes. We could only send around 20 liters for each motorbike, or by helicopter, which is not only more expensive, but it's also quite difficult to arrange a helicopter move. So the main two reasons for which we installed these solar systems were, one, the fuel constraints that I explained, and also the local capacity that we have in Congo to do this kind of installations. We recently found a local company based in Goma, a city in the east of Congo, which had the capacity to do these kind of installations and to do the maintenance of the systems. So that was also a critical factor for us to go ahead with this kind of designs. Otherwise, without the local company, we wouldn't have done it, I guess. Next slide, please. So the design was done by MSF Technical Office. Okay, so basically, based on the current and the forecasted electrical needs of the hospital and previous experiences in MSF with other solar systems and some other solar system design tools, we designed the systems. The solar system for both hospitals are basically the same, since both of them have the very, very similar characteristics in terms of size and electrical needs, except for minor details in the solar systems. Both are more or less the same. So we went for 32 kilowatt peak photovoltaic modules. Okay, each hospital had 2 generators of 9 kVA each, which were only acting as a backup power source. We installed a 100 kVA kilowatt-hour battery bank and a 15 kVA charger inverter. And all this system is for a hospital that is consuming between 2 and 4 kilowatts. Okay, the consumption is quite stable. Okay, it doesn't change much. It increases a little bit during the night due to the security lights, but it's around these numbers. Okay. The system was designed to be working with at least 2 days of low solar irradiance. Okay, we are speaking about an area it's in the middle of the mountains, and long periods of rain. So we wanted to have this autonomy. This is one of the reasons for which we oversized the solar array. Okay, we would have done this system in another place, the solar array might have been a bit smaller, I guess. And also the charger inverter was also oversized because we wanted to have the capacity to adapt the system quickly in case the electrical needs grew, okay, and went beyond what we initially forecasted. That's why we went for this big charger inverter, but we soon realized that with a small charger inverter of about 10 or even 12 kVA would have been maybe a better suit for these installations. Next slide, please. So, as I explained earlier, all the implementation was done by a local company. Okay, they had the capacity to do everything. Okay, so only the design was done by MSF. All the rest was done by this local company. So they source all the materials. They send them from the manufacturer warehouses, which were based, in this case, they were based in China and Netherlands, by sea to Tanzania, then by road to Goma, and from there, MSF helped with the logistics, transporting them to the final destination with a mix of motorbike, helicopter, and trucks in some cases. Okay, then the implementation itself, when we had all the materials, was fairly quick. It only took around 6 weeks for 2 technicians to do the whole system from scratch to the system be completely fully operational. Okay. So as I said, the main constraint for the implementation, it was not the design, what was fairly easy, or the actual work, but mainly the logistics, okay, of sourcing the materials, getting them to the final destination, and everything around it. Next slide, please. So, as we were discussing, the operation and maintenance of these kind of systems is also crucial. Okay, as I explained before, one of the reasons that we went ahead with the kind of system was the availability of this local company that were able to do the maintenance, okay, and solve any kind of technical issues that we might have afterwards. So MSF, we train the technical staff of the hospitals on the basic operations of on the systems and how to use them. Anyway, the solar installations are fully automatic. Okay, so the main task of the hospital staff in this regard is to do the regular maintenance of the backup generators, because the system automatically charges the batteries and adapts the solar output according to the needs, and start the generator whenever the batteries go beyond their maximum depth of discharge. So almost nothing has to be done. Okay. So we signed a maintenance contract with this local company, and they were doing monthly visits. During these monthly visits and these regular maintenance, tasks were mainly just cleaning the solar panels and checking the system cables, connections for any irregularity. But since we have installed the systems, Cursisa has been over 1 year and a half, Kibulube half year. Now we haven't had any problem or any major need beyond this regular maintenance. Also very helpful was that these systems and the type of equipment that go with these systems, they come with a really long warranty. Okay, so that's also something that we took into consideration into building the systems, because these warranties are very easy to implement also. Because these local companies, they have dealers in Africa, and it's quite easy to implement in case needed. And in both places, we also established an internet connection. Okay, just to be able to control and supervise the systems remotely. This has been extremely useful in order to assess the solar system and detect any kind of problem prematurely. Next slide, please. So the cost for each system was around $148,000 US. Okay, this is all the cost, okay, including installation and materials and everything. As you can see, the main cost was the batteries. This is because we decided to go with lithium batteries instead of the normal lead acid batteries. These lithium batteries are around 3 or 4 times more expensive than a regular battery, but considering the longer life and the performance, we consider that the investment was worth it, so we went for these lithium batteries. And also a significant amount of the cost is the lightning protection. Okay? Lightning protection is always a very important part of any solar system, but even more so in these areas of Central Africa that have a very high density of electrical storms. That's why the lightning protection system that we have in place might be bigger than usual, and it's obviously more expensive. Okay. So next slide. This will be finishing. So as I explained at the beginning, both solar systems were allowed the running of second hospital 80-bed, second level 80-bed hospitals. Okay, these are fully equipped hospitals. We have OT, delivery room, laboratory, 24-hour oxygen supply, which is always very important. Also for COVID-19, for example, it's also crucial, the continuous supply of oxygen supply. And also very important also to highlight in this case is that even in a place like Eastern Congo that has a lot of struggles with security incidents and political situation and geographical constraints, both hospitals have been able to run and not be affected by any of these context issues. No, because that would affect the normal supply of diesel to the place. But since then, we have been able to run to have a continuous and good quality electrical supply of both hospitals with I would say less than 1 hour downtime in total, I would say, which for places like this, I would say that is quite an achievement based in my experience. So that's all. Thanks.
Thank you, Inaki, for sharing with us your experience from Democratic Republic of Congo. I'm pretty sure it was useful to our audience. A quick note to our audience, if you have questions, please use the question box on the right side of your screen to send in your questions, and we will address them to Inaki and the other speakers during the Q&A session. And also we will share with you the presentations and the video recording from today in a follow-up email that will be sent to you after the webinar. And moving forward, I would like to invite our third presenter for today, Mr. Talal Kanan. Talal is an independent renewable energy specialist, and he has been implementing renewable energy projects for different international organizations such as the UNICEF in the MENA region. And today, Talal is going to give us practical tips on planning and implementing a PV system for our healthcare facility. Talal, the floor is yours. I'll quickly send you a request to share your screen.
Okay, thank you, Renisha. Did you manage to send the request?
Yes, now you should get a request to share your screen.
Yes, 1 second. Okay, do you see the full screen now?
Yes, I do. Please proceed.
Okay. Okay. Thank you very much, Renisha, and thank you to all the colleagues. Thank you, Inaki. Thank you, Luke, for setting the context, and to everyone involved in organizing this. So, 1 second. Okay. So today, primarily, I won't be talking about why renewables are important for the health system and why it can build resilience, but rather I'd focus more on how you could utilize it and really how you could approach planning and implementing a project from the mere idea of strategizing up until delivering the project or the intervention as a whole. But before we go into the how, I want to just talk about the context in which we're entering for a renewable energy project in a health system. So it's evident that there's huge reliability or there's huge dependency on energy for providing critical health services. And that varies from one part of the health system to another. And so the health system, sometimes it's comprised of health clinics that form the basis of the primary healthcare, and you'd have cold rooms for vaccine and the cold chain equipment, which is also part of the primary healthcare system. And then you'd have hospitals, secondary, tertiary hospitals, other critical facilities. But I want also to add a component within the health system that is sometimes overlooked, which is mobility. All the ones I previously mentioned are primarily dependent on electricity for provision of services, but mobility in particular is primarily dependent on fuel, really to make its effect. So what I would argue is for us to look at the health system resilience, we'd need first to electrify the health system, provide access to electricity, and then make sure that this source of electricity is a renewable and a sustainable one. But before we go further into health facility or health infrastructure electrification, I want to emphasize on the idea of energy for mobility in the health system. From a project that we've been working on under the HERS project, or it's called the Health Integrated Resilience System, which is supported by Humanitarian Grand Challenge and Grand Challenge Canada, we've been exploring the viability and the feasibility of replacing internal combustion engine run or regular fuel-dependent vehicles for vaccine transport and for ambulance with alternative electric vehicles. And electric vehicles in this case that are charged potentially in facilities that are also powered by renewable energy. So when you look at the health system, you look at it from a holistic point of view, and you see not only electrification of mobility, but rather electrification from a reliable and a secure source. What we have seen and what we've observed from the pilot that's currently planning and implementing, we've seen that on the longer term, really the activities are much more competitive. And I'm talking about not few years, but rather of months. Here, you might see the estimate as a bit optimistic for vaccine transport and ambulance of 20 and 15 months. But really, even the conservative estimates of having electric vehicle of $80,000 or $70,000 plus equipment, you'd have a break-even point by months, even like less than 3 years, 2.5 years or 3 years. When considering even like market price fuel of 65-70 cents per liter for fuel. So what I would argue is for all of us, when we look at a health system electrification, health system resilience, we go beyond the traditional electrification of a particular facility, be it a clinic or a hospital or otherwise. But really, when we look at the current problem, based on the highlight that Luke have provided a very comprehensive overview of, in most cases in most cases where the interventions are taking place, you have no energy access at all, be it in sub-Saharan Africa or certain parts of Asia or elsewhere. But in other places, you might have high dependency on diesel generators that really provide the core electricity supply for a particular region or a particular area. And we'd see that when talking from a humanitarian perspective, you'd see that in Yemen, you'd see that in lots of parts of Syria, you'd see that even in the Gaza Strip, where all the health facilities primarily depend on diesel as the main source because of unavailability of a grid, or a grid that is controlled by external stakeholders, instrumentalizing and politicizing it. And in certain cases, you'd have a weak, unreliable grid because of high rationed number of hours or high rationed hours. You might have issues or like natural disasters causing for certain power plants to go off or go out of service, like we've seen in Haiti or Puerto Rico. Therefore, you'd still have certain parts of the grid functional, but you'd have much less number of hours operating. But the solution to all of that in the wide spectrum of problems you'd see in health systems, be it in humanitarian settings or elsewhere, having solar electrification as one of the primary sources of renewable energy and the most prominent and most economically competitive ones as the main primary attraction. And it has been proven that it really achieves economic competitiveness when designed and planned well, and when the circumstances allow. It proves that it does not depend on fuel. It's sustainable, so you don't get stuck in a cycle of fuel dependency when fuel is your primary source of energy, especially when it's controlled by external stakeholders, or when you're in a conflict area, fuel being a commodity that powers a local war economy. And finally, the idea of decentralization, localization. Renewables and solar can provide that resiliency against shock of supply of fuel or shock against supply of electricity from the grid. So in its entirety, renewables not only can provide a competitive or economically viable source of electricity, but one that is resilient really and sustainable as it goes ahead. So going further into the how, when you start, the first step we're talking about here is really as a practitioner in the humanitarian setting, or in the NGO sector, or in the health energy nexus, you'd want to understand what are the applications that are there. Luke, in his presentation, briefly went through the tiers of systems that are there, all the way from like a small system to a kiosk to a mini grid. But here I would just assume that when we're talking about specifically a health facility, we would have those three primary segmentations of systems. One is a conventional off-grid system, where it's solar plus batteries, just as a regular one. The most conventional of those are AC systems, and you'd have less common ones as DC systems, primarily one that loads are also DC. In other instances, you'd have a hybrid diesel, PV diesel system with energy storage backup. So that's possibly the case in Inaki's project with MSF in Congo, where you'd have a diesel generator there as backup when fuel is available, of course. But sometimes you depend primarily on the solar plus storage when the solar is sufficient. Here you'd have also two forms of storage. One is a regular approach to sizing, when you might assume 1.5 days or 2 days of load or of consumption demand. Or sometimes you'd have more of a lean energy storage approach, where you design for 1 or 2 hours of consumption. And basically, this has been proven more effective in hospitals than elsewhere. And finally, it's the same approach of the second categorization, but when you have a grid as well involved. So when you start planning the project and you start really scoping out what you want to achieve, you determine what is the objective of the project. Are you targeting one particular facility, like one remote facility in the suburbs of Congo, or are you, as UNICEF, for example, targeting all of the cold chain infrastructure in a particular country or region, and therefore you select primary healthcare facilities plus cold rooms? Or in some other cases, you might target only critical hospitals to ensure that critical hospitals with specific services are secured with reliable source of electricity. Or in third instances, you might have a holistic approach, an integrated approach for the whole system, the whole health system in a particular country or region, where you look at all tiers, primary, secondary, tertiary. You look at hospitals, PHCs, and you look at the cold chain as well. To inform the strategy, we'd want to also understand the local conditions in the country of intervention. Is there an electricity available Is it a weak? Does it have a weak, unreliable grid? Is it fuel dependent primarily? So it's all diesel generators, or do you have no access to energy at all? And for example, in certain cases in Darfur or Kurdistan in Sudan or elsewhere. So you'd want, based on the above, you need to determine the plan, the conditions of the country, and what you want to achieve. Do you want to have full electrification and full dependency on the system that you're providing, or you'd want to only provide for critical departments or cold chain, for example? So those three components, or the answers to those questions, inform your assessment plan, assuming that you want really to transition a health system from whatever status it is in to a fully resilient, renewable-based system. So the source, scope of facilities that we've mentioned, the strategy of intervention, the status of the system, informs the assessment plan and its design, and whatever resource mobilization you would do later and you would implement accordingly. So when we want to go into the second section, which covers the assessment, we'll talk about the assessment process, the planning phase of it, the collection, the tool itself, and how we can analyze. And after that, we can go through the implementation. But for the assessment, when you want to plan it, it's really in threefold. There's the planning of the assessment in itself prior to implementing or collecting the data, and you'd have then the data collection process, and finally the analysis. When planning the assessment, you'd need all of it would be really informed by the strategy and the scope you've answered in the initial phase, and then you'd really start developing the questionnaire and data collection tools accordingly. And from those data collection tools, you'd want to develop a data analysis framework that answers, or you synthesize the collected information into tangible and actionable information. For data collection tools, I would recommend you check out Kobo Toolbox, which is an accessible and free data collection tool. Some other organizations would have their own tools developed, like UNICEF, they have a tool called Data for Action. Other organizations might have their own internal tools developed. When performing the field data collection process, after you've developed the tool and developed the analysis, you'd want to understand that whoever you're collecting the data with are fully oriented with the tool you've developed. You have a clear plan for the collection and the cleaning of the data, for the quality control, which is a huge issue when collecting data. And finally, after completing the data collection process, you'd go into the third phase and of analyzing and synthesizing the data according to a framework. Today, we will expand slightly on. But for the data collection tool, here I provide an example of kind of a tool we use in a primary healthcare approached health system transition. And it covers 5 main elements that are interdisciplinary, not only energy, but also health concerned. So the first one really would understand when you start, the objective of the first section is to understand the categorization of that facility, the points of contact, the geolocations, the coordinates, and latitude, and other general information about it. Then you start collecting health-related information, the services that are provided or services that will be provided in the future, the classification of the facility, because in certain countries they have their own classification. For a primary healthcare facility, they might have A, B, and C, they might have 1, 2, and 3. And according to each of those classifications, they have their own health service package that's offered. You'd want impact and beneficiary statistics for each of those facilities that you are collecting data from. And accordingly, you'd want to categorize them and according to geography and impact. Thirdly, we'd look at spaces that are available to have the solar system installed, that are in areas that are not in non-shaded areas. Structurally, if you're putting it in a building, that the building structural integrity allows for integration of a mounting system and a solar system with its weights. You'd want to understand if there's an electrical room and the distance between the electrical room and the roof space, or the space where you have the solar system. You'd want to quantify the energy demand based on load and based on the source that you have, and the modularization that you could do, and eventually the electricity infrastructure in the region. Quickly, just I know the frameworks might look a bit intimidating, but just to briefly go through this for a PhD example and then for a hospital. It's really good and important to have a plan prior to initiating the assessment, or prior to start collecting the data, a plan framework that is consolidated with the data collection tool that you have in place. So what really are you going to do with the information that you have? For example, here in a PhD setting, all the energy information we've collected, the energy sources, for example, if it's a diesel genset or a grid, etc., I would reconcile it with the load information that we have in terms of the daily energy consumption to determine the daily energy need and the possible energy required. So what is kind of system required based on this energy demand, current and future demand. And then the roof or space information would allow me to know whether I can have solar there in the first place and how much I can put there as a maximum capacity. And thirdly, the health information allow me to classify those systems. When I reconcile all those three pieces of information, I would know then if I can have a solar system that fits in that particular location and whether that location is a priority or not when developing the comprehensive database for the area of intervention. Because you might be assessing 100 facilities or 200 facilities or even 300 or 400 facilities in a particular region. And that's possible, and there's a lot of organizations, including UNICEF and WHO, are doing such assessments of that scale. But I would recommend here, when synthesizing the data, that you do a modular approach for system design, for grouping really and having ranges for each group of consumption. Like what we have here, for example, and that's just an example that can be different, what can be developed according to the consumption in each particular location. We've developed here 6 modular systems according to range of consumption of 5 kilowatts, 7.5, 10, 12.5, 15, and 20 of solar generation capacity. And based on the consumption, we've started grouping each of the facilities according to that solar system capacity in order to streamline and ease the process for planning and implementation. And as an example of the energy consumption based on load profile, every facility would have its own schedule of the appliances that are there based on them, and the quantity you determine the hours and the load consumption, and eventually the kilowatt hours per day, which is the kilowatt hour is the, for those of you who don't know, this is the energy consumption, the unit of energy measurement that you can quantify the consumption based on it. And this figure really informs the standard approach of how much energy you'd need, and based on it, you'd plan and size accordingly. For hospitals, the story is a bit different. Hospitals are much more complex systems, much more energy intensive. They require much more appliances and much more demand, even in hourly oil consumption. And therefore, the approach for sizing differs a bit. The main characteristics are the same, but 2 things differ here. One is that the energy demand consumption is quantified through a data logger. You'd need to have more accurate forms of data consumption monitoring, and you might have electric devices or electronic devices to quantify the energy consumption based on a particular period. And you might have this for the overall facility, in addition to critical loads, you have a critical section like operation theater, emergency ICU sections, etc. And you'd compare it with the space available. The space available allows you to know, for example, how much you can have of capacity there. And if this is reconciled with how much demand there is, you'd know how much the penetration of that solar system in the mix. And as I mentioned before, you might have it here as a hybrid system with a diesel genset. And critical load, you can determine as well not only a PV diesel system, but if it's a PV diesel system with a critical storage capacity, you'd want to determine what loads would be supplied with critical reliable energy supply when the diesel genset is completely turned off. And first and foremost, obviously, the most important element is energy efficiency as well, which we'll briefly talk about today as well. Which is integrated prior to designing the eventual system that you are planning to implement. So you've determined the plan, you've designed the tool, you've designed the analysis framework, you've collected the data, and you've analyzed. And then you want to build on the results to mobilize resources and plan the implementation. So for the implementation, I'm going to talk about main points briefly, not to go, I might be just going a little bit over time, but just briefly a few points of do's and don'ts for those main phases. Primarily, we'll start with the design and engineering. Options are there for different organizations, both internally, like MSF, where they did the internal design of this as the technical office. Sometimes you'd hire an engineering firm, like a consultancy company, to help you with this. It can be a local company in the area of intervention, depending if the capacity is there, or an international firm. Or sometimes you might want to engage external engineering entities in the area of intervention as well, in addition to whatever internal capacity you might have, like technical NGOs, university research institutions, etc. And the function of the design and engineering phase, or the entity or personnel, is to assess, is to supervise the assessment process, ensure it's validated, especially when there's a distance between, or like a time gap between the assessment itself and the time when you mobilize the resource for implementation. So you need to validate and update the database that you have, and you need to create comprehensive studies for CAD, for lightning protection, for distribution of strings, of layouts, etc. And you'd want to develop the bill of quantities of all the electrical appliances and electrical distribution network you want to have in place. So a few things you need to find. You need to have engineering personnel engaged as early as possible in the process. When you, as I said, you want to have, when the resource allocation is done, you need to validate whatever you have collected. If there's any updates that were taking place, you want to consider the international markets when developing the specifications. And here we'll go into specific, as the MSF project, they've used lithium. Something that's not yet fully conventional, and it's considered to be a bit on the verge because it's expensive, but you need to consider all that is available. You need to prioritize energy efficiency measures before the solar electrification, and you need to consider the critical demands, critical loads in every part of the process. For procurement, and that's a very key and critical aspect that sometimes either makes or breaks a project, and you'd want to consider the options that are available. The first option is one that also MSF pursued in the case study provided by Inaki, is a conventional one where a company that is standard provides the materials and also performs installation services. But the engineering personnel in the organization itself, they develop the specification and they develop the quality control processes. In other parts, and that's sometimes more advantageous, is to segment those processes. You do the procurement yourself as an NGO or a unit agency or development entity for the materials, and you procure them from international markets. And then you might engage local installation companies to do the installation for you. But you need to have in-house capacity for sure, in-house technical and project management capacity to lead such project. And it would be assessed based on the risks available, risks of material delivery, even sometimes of margins if it's too risky and international companies applying, and there's lack of local staff that they determine or they identify, it becomes more expensive. So for materials, it is advisable sometimes to have open international tenders to secure the most competitive prices. Sometimes it's through LTAs, sometimes it's through shortlisted suppliers. Basically, but as we've went through, it's important also engage qualified personnel. Consider, and here I would emphasize on the third point, consider the lifetime costs of the system you're procuring. A very common mistake is that procurement officers or procurement departments only look at the front cost, the upfront cost, and they don't look at the comparison between the different viable options. They look at a lead acid solution and they don't look at a lithium solution, even though if you look at it in a 10-year span, the lithium solution might be much more competitive when compared to the other solution. So in terms of procurement, integrate other unconventional means, not only the upfront costs, long-term costs for the project. And sometimes you can approach from a levelized cost of energy or an LCOE approach. You need to evaluate risks, you need to build on experience and determine the modalities based on all of the above, really, based on the risks and experience and the technology that is. For installation planning, you need to, over time.
We are over time. Could you complete in the next 2 minutes?
Sure, I'll wrap up in 2 minutes. Installation planning, really, you want to consider depending on the size of the project, grouping, clustering facilities according to regions or areas of intervention, standardize as much as possible, look at and consider local codes, local and international codes of design and of implementation, and consider the local considerations and the context. For quality control, you need to engage authorities or relevant stakeholders as soon as possible from early stages in the project. If it's a government, engage the relevant government ministers. If there's no government, engage those managing the health system. Formulate an interdisciplinary supervisory or management committee that combines both people from a technical point of view of health and energy. and local authorities develop quality control standards early on in the process to ensure that things are thought of, and the installation companies have considered all the dynamics. And for sustainability, consider the different options of either going with installation companies or independent company, or engaging the local authorities and the technicians at the facility. Each option might have its pros and cons, and it might be effective in the different contexts in which it's applied. You also need to plan operation maintenance functions from day one. Ensure quality is there, because one of the biggest sources of failure for renewable energy projects is the lack of a comprehensive operation maintenance strategy, and specifically a lack of financial resources and human capacity for future implications. So ensuring that also financial resources are available in addition to the organizational and human resources, and consider the battery replacement costs in case you're using lead acid, or even in case of lithium, consider the 10-20 years implication. Summary of 7 things to keep in mind in case you were not, you're in a hurry. Plan the comprehensive assessment, prioritize needs. I emphasize prioritize needs where electricity is lacking. Engage qualified engineering personnel as early as possible. Determine best value of money in the procurement and not only the cheapest options. And consider advanced solutions like lithium or PERC modules, etc. And include relevant stakeholders, including authorities, while considering the optimal implementation modalities for the different phases, because it differs from one country to the other. And pursue standards in the installation process in all phases of the project, and plan well for operation maintenance. Thank you for your patience, everyone, and thank you, Renisha. And pardon me for taking a bit long. Over to you.
No problem. Thank you, Talal. Then I'll just switch back to my screen first. And thank you to you and all the other presenters for your amazing presentation. And we are now ready to move into the Q&A sessions, and we have a lot of amazing questions pouring in. So maybe I can start with you, Luke. So the question for you is, what are the biggest challenges to scale energy access for the health sector? Is it more about who can pay for it, or is it about last mile distribution or something else?
Thanks. That's a really good question, and I think the answer is it's going to be quite context specific in terms of what the biggest challenge is, and a lot of these challenges, we can address them in parallel, but I like looking at them in a sort of a flow chart where without the right type of data in terms of where are these facilities, what is their current energy status, and what is the actual energy demand, it's very hard to come up with the next step. So with the system design, with allocating or trying to find the right type of technical solutions, as well as figuring out or assessing, are these technical solutions available in country? Are there solution providers that would be able and willing to respond to that demand? So to me, the two work in tandem. Let me just add a third big challenge, which is the enabling environment. And without that enabling environment, perhaps especially at the policy level, so at the national level, at the global level, in terms of prioritizing this issue, making sure that it is included, that health facilities are included both in national health strategies in terms of how much power needs to be allocated, needs to be available to deliver a basic package of health services. Similarly, on the electrification strategies, there really should be no national electrification strategy that ignores public institutions, be it health facilities, be it schools, be it public lighting, street lighting, etc. So to me, I'd say that the policy side is where all of these things can come together, and that is potentially the biggest enabler. Over.
Thank you, Luke. Thank you. I think I'll touch on that last point and ask all of you, because there's a follow-up question regarding the last point, because we all say now, because of the COVID situation, there is a lot of light on the powering health issues, but what would you recommend in a post-COVID world? What should we do so that we do not lose this momentum? So maybe Luke, you can comment on that, and I then go to Inaki and Talal.
Yeah, no, excellent point. And perhaps one that is still very fresh in our minds, that only 6 years ago we were facing an Ebola crisis, and while that didn't reach global proportions, it was a very similar type of momentum that during the Ebola crisis, we clearly saw that electricity was one of the critical aspects to addressing it and to making sure that we actually were able to address it. And then we as a sector were not able to capture that momentum. So I think learning lessons from perhaps the failure of really turning the Ebola momentum into a very strong global powering healthcare priority is would be the first step, and it's definitely one that I think many of us are currently already doing. I'd say maybe one of the differences is that it's not just about COVID-19 today and about isolating and identifying and treating. In a year from now, when hopefully there will be a vaccine, there needs to be a continued powering healthcare momentum, even though we can consider that to be post COVID-19, on the cold chain side, on making sure that vaccines are actually able to get out to these last mile settings as well. So we can use the current responses, the current initiatives, to really build up a much more resilient health sector. But it's definitely a challenge. It's a risk that we all need to be aware of, that we don't just turn our backs and then focus on the next big problem in 2021.
Thank you. Inaki, would you like to add something to that? Like, what do we need to keep in mind that we don't lose this momentum?
Yeah, I guess that one of the main things that we can get out of this is that a strong health system is key in fighting on any of these global health issues. So so having a strong health system obviously implies having reliable and sustainable energy source. Okay, it doesn't matter what type of energy it is. So I guess that could be one of the main takes out of this that we have to consider, and that energy is crucial not only for COVID-19 due to the ventilators and oxygen demands, but always, and as Luke was saying, for the cold chain and everything else. I guess that.
Thank you. Talal, anything to add?
My colleagues have really have nailed it, but I would just add really that we should not be reactive. It's good that sometimes a crisis like this stimulates a response, and from it new innovations and accelerated pace of innovation and of introduction of new solutions advance, but we should not be reactive to this crisis or any upcoming crisis, but we should be proactive in making sure that we do transition to a resilient health system that is based on renewables, regardless of the current crisis. What the current crisis should only help us mobilize further and garner greater resources to achieve that objective. And not only in the health sector, this is really a cross-sectoral approach of ensuring resilience of critical services and critical infrastructure, especially that we are, the time that we are coming might look very similar to those of natural disasters, of such pandemics, where the people impacted the most maybe in countries that are fragile, in countries that are witnessing conflict and weak countries where the states are weak. So we really need to prioritize of ensuring that the critical services are resilient, are the sources and the ingredients that makes them tick are localized, and they're reliable and dependent. So I think we really need to be proactive as a community, be it from the donor side, be it from UN agencies, be it civil society to advocate for it, NGOs, private sector. We should be collectively pursuing that path. And I think we really need to be proactive in it. Thank you very much.
Thank you. Inaki, then I would like to come back to you because we have a lot of questions regarding the operation and maintenance side of the project that you shared with us. The first question is, could you share the name of the local company that you contracted for? Because we got a lot of questions for the name of the company.
Yeah, it's a local company called GoShop. GOSHOP. No.
Thank you. I'll make sure to link it in the webinar documentation so that people can check it out. And then the second question is about, for the operations, about training the technicians. So what do, in your experience, what makes the most sense, training the hospital technicians or actually hiring a private company to take care of the operation maintenance?
I mean, I guess that there are different, those are different things altogether for me. I mean, training the technical, the hospital staff, at least what we do in MSF in this case, but also in other installations, it's basically training them on the day-to-day and very basic maintenance, which I think you have to do it anyway. Okay, but at the same time, having a local company with expertise to do the technical maintenance and the problem solving, no, on this type of installations is also essential, and that's something that you need to have previous to doing all of this. And because this kind of systems, this kind of solar systems, they are quite complex and very difficult to maintain. Okay, not the preventive maintenance, which you can see would be mostly cleaning the solar panels, which is fairly simple, but just solving any kind of problem that you might have with the system, that you need a previously trained technician. Okay, so for us, it would just be too long for us to train these people. So in our case and in my experience, I would only choose people that really have this experience. Okay, not for the operation and maintenance, but also for the implementation. I guess for me is the same thing. No? If you don't have this kind of local capacity available, I wouldn't go for it. Which at the same time, at least in MSF, we are able to find this local capacity almost everywhere. I mean, we find this local capacity, and with local capacity, I mean people with enough experience and knowledge and tools and time and resources to do this type of, let's say, medium to high complex systems in almost every country in Africa. With this, I mean South Sudan, Central Africa, Congo, Niger, Chad. So I'm fairly confident that you will be able to find it in almost any country around the world.
Thank you. And I actually have also one follow-up question to that. It's more about the replacement of the panels or batteries. In your project, when the time comes to replace or get any spare parts, who is going to pay for it, and will the spare, and how would they procure the spare parts?
Well, I don't really know, because as of today, MSF is supporting those hospitals. When the time comes that these panels or the batteries or whatever needs to be replaced, that will depend. So I don't know. If MSF is still supporting the hospitals, I will be confident in saying that MSF will pay for them. If MSF is out of the picture, I don't know, but so I wouldn't answer that. In any case, these type of systems, as you might know, the solar panels, they have a lifetime that go up to 20 years. You know, that would be the maximum strength, I guess. but you can use them up to 10, 12 years with a minimum decrease in performance. Okay, so at least 10, 12 years. And in case of the batteries, that's also one of the reasons for which we chose the lithium batteries. Lithium batteries, according to the manufacturer, which is how we still have very few experience, not only in MSF, but in general with these kind of batteries. The manufacturer says that they can reach 10 years with up to 90-95% of its original performance. That's something theoretical, and they are still very low experience with this kind of batteries to ensure this kind of things. But in experience, I go ahead and say that they will live. That you can be sure that they can live for at least 5 to 7 years. That's for sure. And at least the warranty they come for 10 years. So if it happens in 10 years, for sure the warranty will cover it. And in this case, it will be the local company in charge of sourcing and installing the materials.
Thank you, Inaki. Then I would like to move to Talal. So the question for you, Talal, is are there any specific business models for off-grid energy companies that are most suited to powering health facilities? If you can share any models that you know.
Yes. So in a humanitarian setting, it's a bit challenging to have pay-as-you-go services, especially when the risks are high. So the common model or the common conventional model of implementation is where the project is a donor-funded project. There's a procurement of materials and services, and then there's implementation and installation, and then the entity itself operates the system, the health facility, the hospital, or other facilities. The other model is really for the health facility itself, or the supporter behind it, to pay per electricity, where a company might install the system itself, might be investing in the solar panels and the batteries, but they do not, so it does not incur for the system owner or the health facility anything except for the electricity that they're paying. So it's a kind of a conventional pay-as-you-go model that's conventional in a mini-grid, for example, or elsewhere, even in developed countries. But in a humanitarian setting, and in a setting where there's not very much of a productive activity, like a health facility don't collect fees from people in most cases. So there's not really a revenue generating model where you can sustain payments of electricity. So it becomes more of a burden as well. But in other contexts, this model might be effective when there's a robust payment collection mechanism in the health facility itself, or if it's a private healthcare service provider, sustain itself from the revenue generated. But that's the two, as I mentioned, or the two conventional ones that I'm familiar with. It's just a familiar conventional approach of implementation, or a pay-as-you-go service.
Thank you, Talal. We have a lot of questions coming in, and as you can see, we only have 2 minutes for this webinar. So what I will do is I'll request all our speakers to address them later after this webinar, and we will document them on Energypedia so that we make sure that we answer all the questions that you have sent us. And before we close, I want to ask one final question to all the speakers. Would be, what would be your key takeaways that you want people to take from your presentation or your experience? And please limit it to like 1 or 2 sentences if you have any. So maybe we start with Luke, you.
All right, 1 or 2 sentences.
Yes.
My key takeaway is that while my presentation focused a lot around barriers, around the gap, the scale of the problem, the scope of the problem, what I haven't talked about yet, but what my colleagues here have, is what happens if we get it right. Like the tremendous success not just on the energy side, but on improved health outcomes when we get it right. And it is hard, but it can be done. So maybe that is my key takeaway.
Thank you. Inaki, you are next. Only 1 or 2 sentences, please.
Yeah, I guess in the line of look that even if it looks quite difficult, you can get a fairly good electrical system in place.
Thank you. Talal, you are next.
Thank you, Anisha. I would add to my colleagues that really not only that there's opportunities and it's possible, I would also say that we need to think, we need to be very ambitious. We need to think big. We need to think of transitioning all of the health system and find ways of doing it. And we need to do it together. One of the key problems I've seen is lack of synergy and lack of collaboration within the humanitarian development community, and there's sometimes a competition between stakeholders. We really need to find synergies with organizations that are already there, build on their experience, pursue the best modalities and options, engage the right people in place, and really advance what's possible, because we're all accountable to it of what we can do. That's it. Thank you.
Thank you, Talal, and thank you to all the other presenters for your amazing presentation. As you can see on the screen, we have come to the end of the presentation. And as I promised, I will pass all your questions to our presenter and get them documented on the webinar documentation page. So please look out for that. We'll send a link to the documentation page in the follow-up email, and there you can read the answers to your questions. And as I mentioned, after you close the webinar, our survey will pop up. So please use the survey to tell us what did you like, what did you not like about the webinar, or is there anything, any topics you want us to focus for the upcoming webinars. And with that, I wish you a good day, and thank you so much for staying with us till the end, and stay safe until next time. Thank you. Bye-bye.
Thank you very much, Anisha. Thank you, everyone.